Excuse me. So I just went down to my neighbor next door. Had a conversation with him. I tried telling him how I make a lot of YouTube videos. And I started it off actually by telling him how it's really bothersome that he gets started at 7:30 these days. So the last 2 days he's been getting up at 7:30. He apparently can't sleep is what he told me. So he goes to his backyard and starts hammering away on metal. Right? So that's like really loud. Like he's literally right there. He's not that far away. Our houses are attached, and that's pretty obnoxious. And then I told him on top of that, like, I'm making YouTube videos, and all I'm hearing in the YouTube videos is just the loud shrieking of your saw machine. So he didn't really seem to look like he cared, but I got fed up. I had to tell him, you know, you can't be doing this all day, every day. You don't have a construction license. You're not actually getting any work done. Nor is there a deadline, like, all right, at least I know he'll be done in, like, 2 more days or something. No. This is like an infinitely happening thing, and it's been happening for over a year now. So if he doesn't stop, if he keeps going this entire week, I'm just going to start calling the cops every day. You know, I know what he's doing isn't illegal per se, but it's still noise pollution, and it's still really bothersome, and I'm pretty sure I can make a case for something, because I don't want to be like harassed by this guy for anymore. Anyway, in the last video, we wrapped up pretty much everything that had to do with the colon, and now we're going to be diving into the liver. Okay. So let's take a look. Before the liver stuff even comes up, there's one last topic. Spontaneous bacterial peritonitis. So this is also known as primary bacterial peritonitis. This is a very interesting topic because I've seen questions on it. It's not very high yield, but those questions are almost always kind of far-fetched. Like you can't really make out what's happening. And you might not even think of this. SBP, spontaneous bacterial peritonitis, might not even come to your mind. So this is common and potentially fatal bacterial infection in patients with cirrhosis and ascites, so actual real liver damage. Often asymptomatic, but can cause fevers, chills, abdominal pain, ileus, which basically means constipation, or worsening encephalopathy, which is a normal pathological manifestation of any liver damage. Commonly caused by aerobic gram-negative organisms like E. coli and Klebsiella, or less commonly, gram-positive streptococcus. And the one question I had on it actually had the answer streptococcus, and I couldn't think of any streptococcus that would do this. Like, it just didn't come to my mind. So this is really like a tiny thing, but if you get a question on it, you might as well get it right. So remember E. coli, Klebsiella, any other gram-negative thing, but streptococcus is the only gram-positive one that you really have to keep in mind for SBP. Diagnosis is going to be via paracentesis. Paracentesis with acidic fluid, absolute neutrophil count of more than 250. And the first-line treatment is third-generation cephalosporins like cefotaxime. Right? The third-generation cephalosporins are the ones that had tax and tick and stuff like that in their name, 3-letter words. So that's really all you need to know about this. I don't think I have a practice question for this in my PDFs anywhere. But it's just not that high yield. Just make sure you know about it so that if you do see it in a question or something, you don't go blank on it. Now, here we start looking at serum markers of liver pathology. The best thing you can do for yourself is really know normal values, just like memorize them over time. The more times you do practice questions, you know, you'll open up the entire set of data and you'll find the values and stuff like that, and that's perfectly fine. And yes, the data is given to you on your step 1 too, but knowing it helps a lot because as you're reading it in a question, you'll think of it as you're reading it, and it'll really like help you come to a diagnosis by the time you reach your answer choices, rather than wasting that possible 10 to 20 seconds of trying to look up the number. So there's two different things. There are the enzymes that are released in liver damage, and then there are functional liver markers. So if there's issues with the functional liver markers, that means that the liver isn't able to carry out its job. Whereas enzymes released in liver damage, these enzymes are basically showing you that there is something that's actually causing damage to your liver. Broadly speaking, lab tests used in the evaluation of hepatobiliary disease either assess liver functionality, so PT, bilirubin, albumin, cholesterol, that's the latter half of stuff, the structural integrity and cellular intactness of the liver, which is determined by transaminases, or the biliary tract, which is determined by the alk phos and GGT. So when we look at this top part here, right, aspartate aminotransferase and alanine aminotransferase, we saw these enzymes in biochemistry and what they did. They will both be elevated in most liver diseases, and more than likely it'll be ALT that's elevated. But if the question is about if the question is about alcoholic liver disease, then you need to remember alcohol scotch and tonic, AST, because in alcoholic liver disease, it's actually aspartate aminotransferase that gets elevated. ALT will also be elevated, but AST will be much more elevated. So they tell you here that AST usually will not exceed more than 500 in alcoholic hepatitis. AST more than ALT in non-alcoholic liver disease suggests progression to advanced fibrosis or cirrhosis. Now, if you have severely high aminotransferases of more than 1,000, then the differentials include drug-induced liver injury, such as acetaminophen toxicity. Acetaminophen has a breakdown product called NAPQI that causes liver injury. It could also be ischemic hepatitis or acute viral hepatitis. Normal values of your transferase enzymes is less than 50, right? So here I wrote 8 to 40. It should, no matter what, really be below 50. If it's more than 50, then you're starting to look at things that are actually causing liver injury. These last two things are about the biliary part, right? So the biliary tract, which also comes from the liver. Alkaline phosphatase, we've seen, well, actually this is the first time we're really seeing it if you're going in order from beginning to end, but we're going to see alkaline phosphatase again later on when we get to MSK in bone disease. So alkaline phosphatase is elevated in both cholestasis, where basically bile is not exiting the liver for whatever reason, or not exiting the gallbladder. So maybe you have biliary obstruction or something. Cholestasis, infiltrative disorders, and bone disease, right? So if you have bone disease, you would also have elevated alkaline phosphatase. So to differentiate between bone disease and cholestasis, you look at the GGT, gamma glutamyl transpeptidase. The gamma glutamyl transpeptidase, this guy will be high in various liver and biliary diseases, but not in bone disease, right? And GGT is also associated with alcohol use. So if you have higher ALP, you want to go then also look at GGT to really compare where the ALP is high because of. Is it high because of bone disease or is it high because of liver disease? Functional liver markers are going to tell you about the actual liver functionality. Liver's job is to make bilirubin, make various proteins like albumin. It also helps with platelet function, and it makes your coagulation factors, right? So you have everything here. So bilirubin, total bilirubin should be between 0.1 to 1, and direct bilirubin should be between 0 to 0.3. Right? So direct bilirubin should not be that high. And when we first talked about bilirubin, we talked about how macrophages take stuff from the broken down red blood cells, right? That heme is then eventually made into bile. That first you're going to have indirect bilirubin, which is going to be floating around attached to albumin because it's insoluble. It's unsoluble. It's not soluble in water. Eventually, it'll get to the liver where an enzyme will then make it direct. So direct bilirubin should not be that high. If your direct bilirubin is very high, then there's probably an issue where you're taking indirect bilirubin, you're making it direct, but then you're unable to actually excrete it. Bilirubin will be very high in various liver diseases such as biliary obstruction, where you're unable to release the bile, alcoholic or viral hepatitis, cirrhosis, and hemolysis. Now, depending on which problem it is, either the direct or indirect will be elevated, and we'll see more of that later on. Albumin should be about 4 to 5, right? 3.5 to 5.5 is the actual number, but it should be about 4 or 5. It'll be low in advanced liver disease because you won't actually be able to make proteins. You won't be making albumin, right? So marker of liver's biosynthetic function. PT, or prothrombin time, is normally below 15. 11 to 15 is the normal prothrombin time. It'll be high, prothrombin time will be higher in advanced liver disease because you will not be making the clotting factors. Alright, so if you can't make clotting factors, your PT will be increased. And we're going to see the difference between PT and PTT when we get to the next chapter, HEMONC. Last thing here is platelets. So there's a big difference between what the coagulation factors do and what platelets do. Coagulation factors kind of stop actual like legitimate bleeding, whereas platelets just do the initial thing. So if you have a lack of platelets, you end up getting petechiae, not like actual bleeding, not crazy amounts of bleeding. So platelets, these are going to be low in advanced liver disease also, and this is basically saying you're going to have low thrombopoietin and a lot of liver sequestration, and it's also going to be low in portal hypertension because of splenomegaly and splenic sequestration. And so basically what's happening is if you have advanced liver disease, all your platelets get put away in the liver, and if you have portal hypertension, all your platelets get put away in the spleen. Right, so you have platelets, but you're not really able to use them. The normal number of platelets is 150 to 400,000. If you don't have more than 150k platelets, then you have a lack of platelets, and that's going to start showing whenever you start getting any kind of petechiae. The last thing on this page is Reye syndrome, which is related to aspirin in kids. So this is a rare, often fatal, childhood hepatic encephalopathy, and kids have died because of it, associated with viral infection that has been treated with aspirin. We talked about this when we did microbiology and we discussed influenza. Aspirin metabolites decrease beta oxidation by reversible inhibition of mitochondrial enzymes. Findings are going to be mitochondrial abnormalities, fatty liver, hypoglycemia, vomiting, hepatomegaly, and coma. So you need to avoid aspirin in children, except in those with Kawasaki disease. There, giving aspirin is more important than anything else because Kawasaki can kill kids too. Salicylates aren't a ray of sunshine for kids. This is just a way of memorizing it. I don't really think anyone needs this, but the shine stuff is for steatosis of liver hepatocytes, hypoglycemia, hepatomegaly, infection, not awake, encephalopathy. Really not necessary. Basically what's happening is you have liver damage, and if you have liver damage, that almost always leads to encephalopathy. The liver damage is fatty liver, so steatosis of the liver. And then because your mitochondria are not able to work anymore, TCA is not going to work anymore, so hypoglycemia. Right? Everyone remembers, though, that the only reason you would give aspirin incorrectly to someone is because you think it's a good idea to give to a kid who just has a basic viral infection. But it's not a good idea. Don't do it. Here I have a note saying mitochondrial accumulation of acyl-CoA esters is the pathomechanism of hepatic injury in Reye syndrome. Salicylate metabolites decrease beta oxidation via inhibition of mitochondrial enzymes, thereby preventing ATP production and stimulating triglyceride synthesis. This results in hepatic steatosis and eventually hepatic failure. All right. So acyl-CoA esters all accumulating in the mitochondria is the reason you get the symptoms you see in Reye syndrome. And down here I have two questions. The top one is from Amboss, the bottom one is from UWorld. So let's take a look. A 38-year-old man is admitted to the hospital because of fever, yellowing of the skin, and nausea for 1 day. He recently returned from a backpacking trip to Brazil and Paraguay, during which he had a 3-day episode of high fever that resolved spontaneously. Physical exam shows jaundice, epigastric tenderness, and petechiae over his trunk. 5 hours after admission, he develops dark brown emesis and anuria. Despite appropriate life-saving measures, he dies. Postpartum liver biopsy shows eosinophilic degeneration of hepatocytes with condensed nuclear chromatin. This patient's hepatocytes were most likely undergoing which of the following processes? So this actually is a pathology question, right? This goes back to the principles of pathology and how apoptosis occurs. What they described is apoptosis. 61% of the people got that correct. 32% chose necrosis, and this is not how necrosis occurs. So here's a little revision of pathology, which at this time, after this video, would be a good thing to go back and review. I'm always going to tell you guys that something you should go back and review. And after this video, when we're done with, actually not even after this video, after we're done with all of GIT pathology, you should go back to your pathology principle and just do a little quick run through of it. It's not that big of a principle chapter, and make sure you know the pathology of various things that occur. And apoptosis is one of the first things that they talk about. This patient passed the 3 clinical stages of yellow fever: infection, remission, and intoxication, which is endemic in tropical regions of South America. So now that's a little bit of microbiology there too, which is the kind of stuff step 1 really likes, right? They want to take the microbiology, the pathology, and then some kind of system and really combine it all. You really needed to figure that out yourself from the patient's condition and everything that was happening to him, because they didn't give you anything to tell you that he has yellow fever. They gave you the high fever, but then it went away, and then now he's pretty much dead, right? He is dead. Liver biopsy shows Councilman bodies, which are typical for yellow fever. Apoptosis is the process through which hepatocytes respond to certain hepatotoxic insults, such as acute viral hepatitis or yellow fever, as seen here. On liver biopsy, apoptotic hepatocytes appear shrunken and deeply eosinophilic with condensed chromatin, known as pycnosis, and a fragmented nucleus, which is known as carrier hexis. Necrosis is the most common mechanism of hepatocellular death in cases of hypoxic or ischemic injury, and is characterized by unprogrammed cell death with inflammation. Necrotic hepatocytes appear swollen with prominent membrane blebs and are surrounded by numerous macrophages, unlike the findings that are seen here. Right? Anytime you have necrosis, you're going to have macrophages because they're going to come to clean everything up. There's a lot of histology about the liver too. As I said, GIT is full of histology. So we saw a lot of histo images when we did microbiology, and we discussed the various hepatitis, right? Because hepatitis B has its own things you see, and hepatitis C has a different set of things you see under histology, and you need to know that difference. The next URL question, this one says a 32-year-old woman comes to the clinic due to 6 weeks of bloating and non-bloody diarrhea. She describes having multiple watery bowel movements a day without visible blood. She underwent gastric bypass surgery for morbid obesity 3 years ago. She has no other medical conditions. She is a lifelong non-smoker and does not drink alcohol. Her vital signs are normal. Physical exam is unremarkable. A jejunal aspirate shows bacterial count of, more than 1 to the 5th, or that must have been 10 to the 5th. Yeah, that has to be 1 to the 5th is still 1. More than 10 to the 5th organisms per milliliter, consistent with small intestinal bacterial overgrowth, SIBO. Okay, what serum substance level is most likely to be increased? And then the answer choices are cobalamin, folate, iron, vitamin D2, or zinc. Now, this is a really interesting question. I remember now. Okay, when I saw this question, I was doing it with another student, and I actually didn't know what the answer was for this because I couldn't really figure out what any of this would be. But I was able to actually pick the right answer because it really wasn't, I guess, it is hard. It's a hard question, but it really wasn't that hard to knock out the wrong answer choices. So this is just a woman who has bloating and non-bloody diarrhea. She has watery bowel movements, which makes you kind of think of vipioma. But then you find out that she also has some kind of jejunal aspirate with bacteria, which is not vipioma anymore, right? And she basically now has a small intestinal bacterial overgrowth, and that's what they're calling SIBO. So what substance would be elevated? The answers were everywhere, but 32% chose folate. Oh, okay. Everyone chose random stuff. Like, no one really knew. 32% of people chose folate, and that was right. But many people chose everything else too. No answer choice was left behind. Folate is going to be the thing that's going to be increased. The normal small intestine is colonized with facultative anaerobes, lactobacilli, enterococci, and gram-positive aerobes. Enteric bacteria can produce vitamin K and folate, and that's the thing you needed to know. Pretty sure I had this in red too. I don't know why it's not red anymore. Enteric bacteria. Alright, so this is a little thing that you really need to know. I mean, UWorld's mentioning it, and it's not really taught by first aid, but you can easily get this on your step 1. So enteric bacteria can actually produce vitamin K and folate, both of which would have been the correct answer. Inhibit proliferation of surrounding pathogenic bacteria, and digest unabsorbed dietary sugars and convert them to fatty acids. A Roux and Y bypass surgery typically creates a gastric pouch, which is removed from the remainder of the stomach and attached to the jejunum via the GJ anastomosis. The larger bypassed portion of the stomach and duodenum are attached to the jejunum distally. This results in a closed-ended gastroduodenal limb in which bacteria can proliferate and ferment any food that may be diverted into this segment. SIBO has high vitamin K and folate associated with nausea, bloating, abdominal discomfort, and malabsorption. That's a really interesting, weird thing. I've never really heard about it before until I saw this question. And when I did see this question, I was like, all right, that needs to go in the GIT section because it can actually show up on someone's step 1. Right? It's not really that far-fetched, nor is getting a gastric bypass surgery. That's not that far-fetched either. So since these things are pretty relevant, it's important to remember that if you do have SIBO, small intestinal bacterial overgrowth, that those bacteria are able to make vitamin K and folate. And what you're seeing in this patient are basically symptoms of excess vitamin K and excess folate. The next page goes on to talk about alcoholic liver disease, and you see more histological images now. So every time the book or anything teaches you about histologic images, what you should do is you should Google and find more histologic images, right? Because the images being shown here are specifically images that were chosen to kind of help you learn a specific thing. But on your test, you can have different images that might have different magnifications or some different stain being used, and that can really throw you off if you don't practice looking at different images. So first thing they talk about, hepatic steatosis, which is macrovesicular fatty change that may be reversible with alcohol cessation. So in A, all you're seeing is a lot of fat, right? Everything that's white is basically those hepatocytes are full of fat. Alcoholic hepatitis requires sustained long-term consumption, so people who are just chronic alcoholics. Swollen and necrotic hepatocytes with neutrophilic infiltration. The more notable thing is the Mallory body, which are intracytoplasmic eosinophilic inclusions of damaged keratin filaments. And this is a pretty bad picture of Mallory bodies. So let me see. Let me try to find something better. Mallory bodies. Images. Okay. So when we look for Mallory bodies here, this is the first one that popped up, which is the one we just saw right now in your first aid, right? This one, again, right here you can see it better. This is a much nicer image, right? So this is a lower magnification than the one we were just looking at, and you can see a bunch of Mallory bodies, right? All these squiggly things that kind of look like they're parasitic infiltrations inside. These are all Mallory bodies, all right? This is a really good image actually. It's super clear, so I'll put that here. Right, so Mallory bodies you have to be able to identify, because if they give you Mallory bodies on your step 1, that's pretty much them giving away the answer to you. It's alcoholic hepatitis, all right? And the other differentials are going to be everything else, like fatty liver, hepatitis A, hepatitis B. It's all going to be on your test, so you want to make sure you don't pick the wrong thing. But you see how I found like a better picture than was given, or a different version of the same picture? It's really important to do that, because one picture alone isn't enough training for you to be able to, catch what you're going to be looking for on your own step 1. And also remember that alcohol, scotch, and tonic, right? Or make a toast with alcohol, but I just call it AST, alcohol, scotch, and tonic. I think that was in the USMLE RX mentioned. So alcohol, scotch, tonic, basically in alcoholic hepatitis, AST is more elevated than ALT. And remember, neither of these things will ever be more than 500 though. If you keep getting this kind of injury and shit like that, then you eventually end up having alcoholic cirrhosis, which is the final and usually irreversible form. Sclerosis around the central vein may be seen in early disease. Regenerative nodules surrounded by fibrous band in response to chronic liver injury will eventually lead to portal hypertension and end-stage liver disease. All right. So in this image right here, all the blue stuff you're seeing is basically fibrosis. All right. Fibrosis, sclerosis, all of that, and it's not supposed to be there. The liver doesn't have any of that. All right. Patients with hepatic cirrhosis will have a higher bleeding tendency and are likely to be anemic. Hepatocytes are damaged and can't do their proper jobs, which includes making coagulation factors. Anemia can have multiple reasons, but may result from hypersplenism due to the portal hypertension, chronic GI bleeding, folate deficiency, or hemolysis. Right, so basically being a chronic alcoholic is a big issue. Now, if you have non-alcoholic fatty liver disease, right, up here, this one was alcoholic fatty liver disease. So you got hepatic steatosis because you're an alcoholic, and hopefully if this patient stops drinking, that goes away and everything's better. But if you have non-alcoholic fatty liver disease, and this is a metabolic syndrome of insulin resistance. So in this case, ALT is more than AST, all right? Insulin resistance, obesity leads to fatty infiltration of hepatocytes, which causes cellular ballooning and eventual necrosis. This may cause cirrhosis or hepatocellular carcinoma and is independent of alcohol use. So more than likely, the question will tell you this patient never drinks, right? So if a patient that never drinks is now presenting with fatty liver disease, you immediately want to think of all that fat and obesity is related to insulin resistance, right? Obesity itself is directly related to insulin resistance. Okay. At the bottom here is a discussion of something we've already quite talked about in biochemistry metabolism, hepatic encephalopathy. Cirrhosis leads to portal systemic shunts, right, with all the different portal system and systemic system blood vessels that we've already looked at. That portal systemic shunting leads to decreased ammonia metabolism. So now you end up getting neuropsychiatric dysfunction. Reversible neuropsychiatric dysfunction ranging from disorientation, asterixis, to difficult arousal or coma. Triggers are high ammonia production and absorption due to GI bleed, constipation, or infection, or low ammonia removal due to renal failure, diuretics, or some kind of bypassing of hepatic blood flow because of the TIPS thing. So one thing I want you guys to pay attention to is that GI bleed and constipation in such a patient with cirrhosis can actually lead to hepatic encephalopathy. And that's a very tertiary kind of question, right? You can get a question about a patient with a GI bleed for whatever reason, and now they're presenting with hepatic encephalopathy, then you can go ahead and safely assume they must have some kind of liver cirrhosis or some reason they're unable to metabolize ammonia. Hyperammonemia is discussed in biochemistry on page 82. So I'm going to go back to that in a little bit, but I think this note might be everything. So right here I wrote, ammonia is produced by the GIT as a result of catabolism of glutamine and GI bleeding. Of catabolism of glutamine, and GI bleeding causes increased nitrogen delivery to the gut in the form of hemoglobin, which is then converted into ammonia and absorbed into the bloodstream. The ammonia then enters the liver and is detoxified to urea. In chronic liver failure, portosystemic collaterals impair this detoxification. Accumulation of ammonia causes increased inhibitory GABA and impaired excitatory glutamate and catecholamines. So before I do the question at the bottom here, I'm going to go back to the topic in biochemistry. And pretty much after this chapter today, you guys should come back over here and look at this too, hyperammonemia. So hyperammonemia, here they're talking about asterixis. The main thing I would really want to look at is this diagram right here, right? So for some reason, whatever the reason might be, you have a lot of ammonia, right? That's what hyperammonemia is. That's what that patient in even that page over there has, right? Hepatic encephalopathy, unable to metabolize your ammonia, so all that ammonia is just sticking around. So what happens when you have all that ammonia sticking around? So you can see ammonia can combine with alpha-ketoglutarate to make glutamate. And glutamate is necessary for making GABA, which is inhibitory, right? It uses vitamin B6. However, if you have so much ammonia still sticking around, that ammonia then combines with glutamate and makes glutamine. So what happens is you run out of glutamate and you run out of alpha-ketoglutarate. And that's really bad. Without alpha-ketoglutarate, you're not going to be able to do your TCA. And without glutamate, you're not going to be able to carry out the inhibitory things. Right? So this presents with flapping tremor, slurring of speech, somnolence, vomiting, cerebral edema, and blurring of vision. Right? You can see that the excess ammonia depletes glutamate in the CNS, and it inhibits TCA cycle because you lost all your alpha-ketoglutarate. So it's really important to make sure you understand this little thing about hyperammonemia, because this segment right here is directly related to liver pathology, as we're seeing now that we're up to liver pathology and GIT. So now here we have a question. This one says, a 68-year-old man comes to the emergency department due to abdominal pain and nausea for the past 2 days. He has a history of atherosclerotic cardiovascular disease and underwent coronary artery bypass surgery 2 years ago. But today he's presenting with abdominal pain. So right here we can already stop and we can kind of start thinking of that. Remember the GIT version of an MI, which is just a mesenteric ischemia, right? So you have atherosclerosis of either the SMA, IMA, or celiac artery, which causes actual ischemic pain and injury to your GIT. That might be what this guy is having because he has a lot of atherosclerosis issues. Abdominal exam reveals mild diffuse tenderness and decreased bowel sounds. Lab studies are as follows: sodium 142, chlorine 104, bicarb 12, creatinine is 0.8, pH is 7.25, and PaCO2 is 29, with lactic acid being high. Right, so this guy has acidosis. ECG shows absent P waves and an irregular rate and rhythm. Okay, so that's kind of sounding like AFib as well. CT scan of the abdomen reveals colonic wall thickening and no enhancement with IV contrast. Urinalysis shows acidic urine. Renal metabolism of what amino acid is most important for maximizing acid excretion in this patient? Any question about hyperammonemia, the answer is almost always glutamine. Right? This patient has acute ischemic colitis, which is the MI of your GIT, which is most likely due to an embolic disease related to his AFib. The ischemic bowel undergoes anaerobic metabolism, causing lactate accumulation in the blood that leads to an anion gap metabolic acidosis. Acidosis stimulates renal ammoniagenesis, a process by which renal epithelial cells metabolize glutamine, generating ammonium and bicarbonate. Ammonium, which is NH4+, are transported into the tubular fluid and excreted in the urine, while peritubular capillaries absorb bicarbonate, which functions to buffer acid in the blood. Right? Treatment is using anything that helps you make more NH4+. So either lactulose or some antibiotic that kills gut bacteria which are making NH3. Right? So whatever you can do to stop NH3 production and increase NH4 production would be the treatment. This guy, he has renal, where did they say it? Yeah, renal ammoniagenesis, right? Acidosis is stimulating renal ammoniagenesis, and that's actually requiring metabolism of glutamine, and this is trying to help him. It's going to help him and make things better. And his entire case scenario is related to something we talked about in the last video, which was discussed right here, right? Acute mesenteric ischemia, right? Critical blockage of an intestinal blood flow, often an embolic occlusion of the supreme mesenteric artery, leading to small bowel necrosis, abdominal pain, out of proportion to physical findings. And he actually has a reason to have that embolic occlusion. He has two reasons, actually. He has the atherosclerosis, and he has AFib. Right, so he's just not that healthy to begin with. Back on page 82 in biochemistry, we actually talked about a bunch of stuff regarding glutamine, right? In conditions of hyperammonemia, glutamate becomes the limiting factor and is compensated by amination of alpha-ketoglutarate from TCA to form more glutamate through glutamate dehydrogenase. The glutamate then combines with more NH3 to make even more glutamine, right? So by combining all these things with NH3, you're getting rid of all this excess ammonia you have, right? So glutamine will be very high at the end of the day in patients who have hyperammonemia. And if you look at the two questions at the bottom here, the answer to both of them is glutamine, right? In the first one, they ask, in the presence of hyperammonemia, what amino acid is always increased? Glutamine. The next one says, what is the most likely to be elevated in his astrocytes? And this question was about hyperammonemia too. Again, glutamine. Glutamine is a really important thing that you want to make sure you remember, because that's the end product that you try to make in an effort to get rid of all your NH3. So that takes care of hepatic encephalopathy, which you can see in almost any case scenario. And right now, the case scenario we saw was practically a GI bleed, right? It was ischemia of his mesenteric artery. And we're going to see more cases like that later on as well. Now, the next page here, this starts talking about hepatocellular carcinoma or a hepatoma. And you have two images here. This CT scan over here is doing an excellent job showing you clearly this is some kind of cancer inside the liver. And the liver is really large, right? The liver's gotten super big because it almost has like another lobe in there now. And here you're seeing a gross image of a liver cancer. So this is the most common primary malignant tumor of the liver in adults, associated with hepatitis B virus and all other causes of cirrhosis, including hepatitis C virus, alcoholic and non-alcoholic fatty liver disease, autoimmune disease, hemochromatosis, Wilson disease, and alpha-1 antitrypsin disease. And also specific carcinogens like aflatoxin, which is directly related to aspergillus, may lead to Budd-Chiari syndrome, and we're going to see what that is soon. Findings are jaundice, tender hepatomegaly, ascites because the actual sinusoids are damaged, polycythemia, anorexia, and it can spread hematogenously. Diagnosis is actually by elevated alpha-fetoprotein, and then you could do an ultrasound or CT, MRI, or even a biopsy to try to actually, confirm the diagnosis. So you need to know what things look like in hepatitis B and hepatitis C and what they're related to, right? This is something you would go back to in microbiology to review. I already did the review for urea cycle stuff. Well, not urea cycle, but hyperammonemia just now with you, right? We went back to biochemistry, reviewed hyperammonemia, and then came back here. now let's take a look at hepatitis B and hepatitis C for microbiology, because that's a pretty quick thing to look at, but the more times you look at it, the significantly more better you get at it. The significantly better you get at it. Yeah, okay. So right here, right? In microbiology, virology, you have hepatitis viruses. It's really easy to remember what they are because the first, middle, and last are all positive RNA. The negative RNA is the deficient one, HDV, and hepatitis B virus, which is the big boy, is the double-stranded DNA, right? So hepatitis B is almost always going to be related to sex, unsafe sex, multiple sexual partners. Hepatitis C virus is almost always going to be related to IV drug abuse. And that's what you're going to be trying to look for in questions. What does it look like clinically? B is just going to look like serum sickness. So you're going to have fever, arthralgias, rash, and it can progress to carcinoma. C is going to have cirrhosis or carcinoma straight up, because what happens is, they tell you right here, hepatitis C virus lacks the 3' to 5' exonuclease activity, so it doesn't do any proofreading. This leads to antigenic variation due to mutations of the HCV envelope. So it keeps changing, so you can't really beat it, and you're going to keep trying to beat it, but it's not going to work. So let's see what you're supposed to see in biopsy. So right here, this image here, this is ground glass. I've shown you guys a couple times what ground glass is supposed to look like. If you don't know what ground glass looks like, you've definitely seen it already. So you should Google what ground glass is supposed to look like, and you'll find a bunch of images of ground glass. This is ground glass appearance, right? And this thing is for HAV, right? Hepatitis A. When we go down to this next page they talk about just hepatitis B versus hepatitis C. And let me see, I have this one, I believe. Yeah, hepatitis B again, right? Let me see, HIV spotty necrosis, councilman bodies. Oh yeah, okay. But hepatitis B is the one that has the ground glass stuff. Isn't this HIV ballooning degeneration? Okay, because ground glass also looks very similar to this, but you wouldn't have the ballooning. Basically, in liver biopsy of hepatitis B, you're going to see a ground glass appearance, but there should be nothing else in there. There shouldn't be any councilman bodies or any kind of weird ballooning, and you will have cytotoxic T cell damage. With hepatitis C, the biopsy under a microscope will show you macrovesicular steatosis. You're going to see a lot of fat. So a lot of something like this that you have right here, a lot of big white circles. I could have sworn I had a bunch of pictures to show you. Oh, this is actually perfect for ground glass, because you see this cell, this one right here, all of these guys, these are your ground glass cells, right? And you can see that this is very different from what we just looked at right here for hepatitis A virus, right? Although this is pretty similar to ground glass, all of these guys are pretty white, and they're kind of expanded because that's ballooning degeneration. They don't have the pink in them anymore. That's hepatitis A virus. Hepatitis B has the ground glass appearance, which is these lighter guys that aren't as purple as the others, but there's no ballooning degeneration here, right? And then hepatitis C, I still have to find that picture. Wow, I thought I completed that. Let me put that in there right now. Hepatitis C histology, macrovesicular. Let's see what we can find. Sometimes it's a little hard to actually find good pictures of these things. This looks pretty legit. Acute and chronic infectious hepatitis. Let me see what pops up. No. I mean, this is probably a really good article, but what is this? Lobular disarray, hepatocellular degeneration. You don't really do much periodic acid shift for hepatitis. Chronic viral hepatitis, mononuclear portal inflammation is variable. Lymphoid aggregates, sometimes with germinal centers, are common in hepatitis C, which is definitely a thing. I think I've seen a question on that before too. Did they tell you? Yeah, lymphoid aggregates. They don't mention the... See, right here I wrote it. Histology will mainly be within portal tracts, and that's kind of what we're seeing right here. So let me put that image right here too. Copy over. Let me see. This information right here. So chronic viral hepatitis C, right? Mononuclear portal inflammation, yeah, right. And this is your portal tract having inflammation, And then, let me see, I wanted to find a better picture of the actual, no, this is ballooning degeneration, which you usually see with HAV. But you see how this is really cool? This is a great way to like explore more pictures, and this is what you're supposed to kind of do when you have to work with histological images. So this is another portal bridging fibrosis and chronic hepatitis C, right? And you can see the fibrosis. That's all the blue stuff in this image. What the heck is this shit? Oh, an ad. Okay. What is this? This should be ground glass hepatocytes and chronic hepatitis B contain hepatitis B surface antigen, right? And very similar to the stuff we looked at for hepatitis A as well. But what you're really looking for is this cell right here. You see this one? This is a ground glass cell right here. There's this guy over here. Those are your ground glass cells that you're seeing in hepatitis B. But there's no... This also has ballooning degeneration, which can occur in other guys, but ground glass doesn't occur in A. Positive cytoplasmic staining for hepatitis B surface antigen with perinuclear crescent shaped. Okay. So now they're talking about B. Chronic hepatitis C, the bile duct is infiltrated and almost obscured by mononuclear inflammatory cells, which is pretty similar to what we just saw right now. Oh, this is it right here. Yeah, see, macrovesicular hepatic steatosis, a common feature in hepatitis C, right? So that's the other thing we need here. This is also hepatitis C. Let me put this right here. Right, so we can have that. So these are actually really good images. I'm going to spend time later on adding it to this page for the people who bought the PDF, because I send out an update to everyone who buys the PDF at the end of every month and the 15th of every month. So people who are going to get the next update, I'll make sure I point it out in the email that I let them know where I added new things, because these are pretty good images. So this one is your hepatitis B ground glass appearance. We can see that. This is hepatitis C. What was the other stuff they were showing you for hepatitis B just now? Oh, this thing. Yeah, but you can do this kind of core staining for any hepatitis, so it's not really significant. But I'll take this picture because this is pretty different from the one we already have here. Yeah, hepatitis B right there. Okay. Alright, so ground glass. Ground glass, as soon as you see ground glass, you want to think of hepatitis B. Anytime you see a lot of lymphoid aggregates and macrovesicular stuff, that's hepatitis C. That's a lymphoid aggregate. So you can see clearly big difference from stuff on the left and stuff on the right. And then with A, this A image here, histopathology demonstrating HAV spotty necrosis. Ballooning degeneration, you also see mononuclear infiltration on the top left, and you will find calcium bodies, which are eosinophilic apoptotic hepatocytes, as seen in the direct center of the image. A small pink cell with pink nucleus and no white. So these guys, okay. All right. So it's pretty important to be able to like practice out looking at histopathological images, because the more you do it, the better you get at it, and you will have that popping up on your test. You do need to know it, because if you don't, then when they throw any kind of histological thing at you, you might get really confused and actually either give up or get the question wrong. So that's not going to go too well. So that was your hepatocellular carcinoma stuff, right? Really problematic things. This here is a question regarding the aflatoxin, which you can't forget. If you forget about the aflatoxin in Aspergillus from microbiology, then questions like this are just going to seem very confusing to you. So this one here says, a 67-year-old man comes to the physician because of a 4-month history of fatigue and weight loss. Physical exam shows jaundice. The liver is palpated 3 centimeters below the right costal margin. Serum studies show an elevated AFP and a prolonged PT. Genetic analysis of a liver biopsy specimen shows a GC to TA transversion in codon 249 of the gene coding for the TP53 protein in affected cells. Don't get intimidated by that. Basically, all that's telling you is there's a mutation in TP53, right? So that's bad. That means he's going to be prone to cancer. What risk factors is most associated, or what risk factor is most specific to the patient's condition? So you know that this question about a 67-year-old man is clearly about elevated AFP and prolonged PT being directly related to the liver, right? Prolonged PT because the liver is not functioning, AFP being a huge sign, right? They said it to you right here. Let me see where they mentioned AFP, cirrhosis. Let me see, they did mention it just now. Where was it? Oh, wasn't it on this page right here? Actually? Oh yeah, there you go. AFP, elevated alpha-fetoprotein. Anytime you have hepatocellular carcinoma, you have a very good chance of having elevated alpha-fetoprotein. So the information they gave you in the question alone was enough for you to figure out hepatocellular carcinoma, and the reason for it was the TP53 mutation, but they want to know about our other risk factors. So anything else that's here, anything else that's on this page, HBV, CV, any kind of liver disease, were all good answer choices, but they didn't have any of that. They had the aflatoxin. So signs of hepatocellular carcinoma are transversions in codon 249 that raise suspicion for a history of aflatoxin B1 ingestion. Aflatoxin is produced by some strains of the mold Aspergillus. A metabolite of aflatoxin B1 interferes with proper DNA transcription of TP53 through an inactivating mutation resulting in the base transversions seen in this case. This mutation can be found in up to 60% of individuals with hepatocellular carcinoma in areas with high levels of exposure to aflatoxin, which is usually going to be in the farming world. Okay, then they go on to talk about other liver tumors, right? Other liver tumors. So what are other liver tumors that you can get questions on? There's angiosarcoma, which is always related to blood vessels, cavernous hemangioma, hepatic adenoma, and then of course metastasis. Angiosarcoma is a malignant tumor of endothelial origin, which is why it's called angiosarcoma, associated with exposure to arsenic or vinyl chloride, and this will be given to you in the question. Or this will be the answer choice, and you'll have to figure out is the patient has angiosarcoma, and then pick one of these things as the answer choice. But overall, pretty straightforward stuff. Cavernous hemangioma is the most common benign liver tumor. It's a venous malformation. It typically occurs at age 30 to 50. Biopsy is contraindicated because if you do try a biopsy, you can risk hemorrhage. And this thing can also be seen in other organs, as you're going to see in this question right here. So first I wrote, ultrasound would show a well-demarcated, homogeneous, hyperechoic, because it's highly vascular, mass surrounded by normal liver tissue. It may enlarge if patient has hormonal therapy, like being on oral contraceptives. Microscopically, these tumors consist of cavernous, blood-filled vascular spaces of variable size, lined by a single epithelial layer. Most patients are asymptomatic and prognosis is excellent with surgical resection. But look at this next question. This is the same disease but not in the liver. A 30-year-old man with a history of epilepsy comes to the office. He has a history of recurrent seizures that start as jerky rhythmic movements of his left leg and gradually spread to involve the entire left side of his body. They describe more things about his seizures in the question stem, so I took it out because it wasn't fitting here. Surgery is performed to remove the lesion, and the excised brain tissue shows a 1.5 centimeter mass composed of engorged purplish clusters, basically a lot of blood vessels. Microscopy shows numerous dilated capillaries with an endothelial lining separated by a thin layer of fibrous connective tissue. What is the most likely diagnosis? And the answer was a cavernous hemangioma, but in the brain. Alright, so you can see that 1.5 centimeter mass that they took out is exactly what you're going to see in the liver too. Right, you're just going to see engorged purplish clusters, numerous dilated capillaries, all of that, because this is a tumor of venous malformation, very similar to angiosarcoma in the sense that it is endothelial origin also, but not the same thing, because angiosarcoma is due to arsenic and vinyl chloride and has a different kind of mechanism. These frequently involve deeper tissues of the body like the liver and the brain. Gross examination reveals a mulberry-like appearance due to their purple vascular clusters. Their histological composition is made of dilated blood vessels with a thin adventitia lacking elastic fibers and smooth muscle. The reduced structural support gives them a tendency to leak, causing recurrent hemorrhage. In the brain, these can cause neurologic deficits and seizures due to compression of the surrounding tissue and irritation from recurrent bleeding. Okay, it's pretty straightforward, not the weirdest thing, but it also should be pretty easy to catch in a question. If this question, or if any other question like this also talks about vinyl chloride or arsenic, then you go with angiosarcoma instead. The next one, hepatic adenoma. So this is a rare benign liver tumor often related to oral contraceptive or anabolic steroid use, may regress spontaneously or rupture, leading to abdominal pain and shock if it ruptures. Right, but it's just an adenoma. It's not the craziest thing. It can't necessarily kill you, but if you have a patient who's on oral contraceptives and nothing else is really given in the question, then you would come and pick hepatic adenoma. And of course, metastasis is here. Any GI malignancy can metastasize to the liver because of your portal vein, right? You remember your entire portal system drains all of your GIT, and I showed you a picture earlier too. Let me see if I can go back to that. Pretty far up actually. Yeah, right here. So this image. So here you can see this is your portal system, right? And you see your portal system drains from your spleen, all of your stomach, your duodenum, and then your small intestine and large intestine. Everything is kind of being drained into the liver, right? So any GI malignancy can drain into the liver. And one of the reasons I wanted to come back to this image is because I kept stressing when we first looked at this that it has a weird design, right? The anatomy of this thing. It has two legs, one leg going this way, which is your splenic vein, and the splenic vein is the one that gives you your inferior mesenteric vein, and you need to remember that. The inferior mesenteric vein is not its own branch, it's a branch of the splenic vein. Superior mesenteric vein is its own branch. It's just a continuation from the portal vein. Okay, so the superior mesenteric vein is basically the portal vein, but it gets a different name once it's doing different things. Alright? But inferior mesenteric vein is a branch of your splenic vein. So all in all, though, we can see here that any GI malignancy can get drained because of the portal system, can get drained to the liver. So GI malignancies, breast and lung cancer, most common overall, metastases are rarely solitary, which is true, right? Anytime you have a metastasis to the liver, you won't see just one lesion, you'll see multiple lesions throughout the liver. This next part right here talks about Budd-Chiari syndrome, and we have this drawing. I'll make it big after we read this. But Budd-Chiari syndrome basically is a thrombosis or compression of hepatic veins with centrilobular congestion and necrosis leading to congestive liver disease. You note hepatomegaly, ascites, varices, abdominal pain, and liver failure. Absence of jugular venous dissension, which is now taking you back to cardiovascular. Associated with hypercoagulable states, polycythemia vera, and postpartum state, as well as hepatocellular carcinoma. May cause something called the nutmeg liver, which was also something we discussed back in cardiovascular. So what's happening here? So if you look at this picture, you have your inferior vena cava, right, with its multiple veins that are going to be draining from inside. So this is the connection of your portal systemic stuff in the liver. Your portal vein brought blood into your hepatocyte, and if you look at the hepatocyte right here, right, you have your portal triad and everything, and then blood is coming back into your inferior vena cava, right? So what happens in Budd-Chiari syndrome? You end up having a compression of the hepatic veins. Those are the veins up here, right? Compression of those hepatic veins, which are part of the inferior vena cava, and that causes blood to be stuck in the liver itself. So you get congestion in here, right? And necrosis and all that, and things get really bad for the liver itself. So now, previously we saw something else. We saw portal vein thrombosis, where if you had congestion here, something wrong happened here, blood wouldn't come into the liver, so all the blood would stay in your GI system, and you could be coughing up blood and stuff like that, right? But you won't have ascites because your liver itself is going to be okay. In this case scenario, we're causing a blockade of either the left, middle, or right hepatic vein. So basically now blood has reached the liver, but it's unable to go out of the liver. So all the liver is going to be full of blood, and you're going to have a lot of issues in the liver itself, and this will present with ascites. Right, so big difference between Budd-Chiari and portal vein thrombosis, right? This is a thrombosis of your hepatic vein. So basically, you could call Budd-Chiari hepatic vein thrombosis, and that's going to cause blood to back up into your liver. Last thing they talk about on this page is your alpha-1 antitrypsin deficiency. This is misfolded gene product protein aggregating in the hepatocellular ER, leading to cirrhosis and PAS-positive globules in the liver. And that's what you're seeing here. All the dark globules, right? I can't make the picture bigger, but the dark red globules. You see the maroon-colored globules? Not the black ones, but the maroon-colored globules, like this one right here. Those are your PAS-positive, because PAS makes it that color. PAS-positive globules in the liver. This is a co-dominant trait, so this is now a genetics thing also. It's a co-dominant trait. Often presents in young patients with liver damage and dyspnea without a history of smoking. So right now what we're looking at is a disease that's shared between GIT and respiratory, right? This is something that's causing liver damage, but it's also causing dyspnea because it's causing pan-acinar emphysema. It's causing respiratory damage, right? They tell you here that in the lungs, low alpha-1 antitrypsin activity leads to uninhibited elastase activity in the alveoli. Normally, alpha-1 antitrypsin stops elastase from doing its job. Now, without the alpha-1 antitrypsin, elastase will continue killing elastic tissue, leading to pan-acinar emphysema. So now you get a patient who has emphysema, and it's not due to smoking. Does the patient smoke? They could be a smoker, but generally, if step 1 is feeling nice on a certain day, they will tell you that the patient does not smoke, right? So over here I wrote, although alpha-1 antitrypsin deficiency patients may not have a history of smoking, which means their symptoms are not due to smoking, it does not mean that they will always not smoke. AAT deficiency patients can have a history of smoking, and smoking will dramatically increase the risk of pan-acinar emphysema by inducing inflammation, which increases neutrophil and macrophage activation. Discourage smoking, no matter what your patient has, but especially in AAT. AAT deficiency leads to emphysema, which causes a decreased FEV1 to FVC ratio, an increased total lung capacity since the lungs hyperinflate, and a decreased DLCO, the diffusion capacity of carbon monoxide, due to destruction of alveoli and adjoining capillary beds. Histologically, you note intracellular granules of unsecreted alpha-1 antitrypsin within the periportal hepatocytes, like they show you right here, the dark maroon spots. They stain a reddish pink with PAS and resist digestion by diastase, an enzyme that breaks down glycogen, which means it's not glycogen, right? Diastase resistance basically tells you, if you wanted to check if this is, remember PAS can actually stain glycogen too, but if you want to check that whether or not this is glycogen, you now put diastase in it, and if diastase breaks it down, then you know it's not glycogen. Yeah, when you go check all my playlists, you should be able to find, in my channel, you should be able to find the playlist called Full FA 2019, which is this one right here. This is the one everyone should be watching, because this is the one I'm adding on to. Like, the video I'm doing right now will also go in that playlist, and we're basically up to here right now. So GIT pathology. I finished up everything else before it though, so I have redone biochemistry and all of that stuff. We did all the cardiovascular and endocrine, and we're more than halfway through GI pathology. But if you need to watch something that I haven't done yet, like maybe the next few things, like neurology, psychiatry, reproductive, respiratory, any of that stuff, then you can go definitely watch any of the 2018 playlists, because those videos are just fine too. It's just now I'm making all these videos over again because I've added so much to the book, and I want to have it all in one playlist, so I can just give that playlist to anybody and they can go through their entire step 1 prep. And I'll also be able to do an hour count to see how many hours it'll take to get through the whole thing. Alright, so that was all your alpha-1 antitrypsin stuff. There's a question here, and then we'll end the video for now. So this one says, a 43-year-old man comes to the office with yellowing skin and shortness of breath with exercise. The patient had prolonged jaundice after birth, but it resolved and there were no episodes until now. On physical exam, expiration is prolonged with scattered bilateral wheezes. He does not smoke or do drugs. Lab results show 140,000 platelets, which is low, right? We just saw that 150 to 400K was the normal amount of platelets. Total bilirubin of 4.1, which is very high. ALT of 90, which is elevated. Chest x-ray reveals hyperlucency of lung fields and flattening of the diaphragm. So that's emphysema right there. Abdominal ultrasound has increased liver span and echogenicity of the liver with no masses. This patient has which condition? Well, if we're talking about liver and respiratory issues in the same patient, it must be alpha-1 antitrypsin deficiency, and that's what it was. The patient has symptoms of liver disease, COPD, or more likely emphysema, and a history of neonatal jaundice. A1AT is produced primarily in the liver, and it inhibits neutrophil elastase. Deficiency leads to pancreatic emphysema. Liver disease is most concerning and can lead to cirrhosis, leading to hepatocellular carcinoma. All right. So we talked about a lot of different things related to the liver, and on the next page we'll talk about a different set of things related to the liver, which are more so related to bilirubin and bile excretion. Right now we were talking about things that are directly about the liver itself, but not the bile duct. Now we're going to be talking about the bile duct and all of that, where we really start seeing jaundice. So I'll continue that in the next video, and then we'll wrap it up. We'll finish up GIT pathology by also talking about the pancreas and its various pathologies.